So I'll be presenting to you an assessment of 12 months retention among children less than 19 years living with HIV in a reference hospital in Yaounde, Cameroon. We're going to follow an agenda which will begin with an introduction and then a summary. Then we'll state the problem and we'll move on to a background. Then we'll describe the methods we used and then we'll discuss the results and give conclusions and next steps. So it is now known that suboptimal retention is one of the major challenges which HIV/AIDS programs face, and this is more pronounced in the pediatric population and in the adolescent population. So WHO has identified a list of multiple factors that are known to play varying roles in causing loss to follow-up that leads to suboptimal retention. So as a summary, we had that objective to assess 12 months retention among children living with HIV less than 19 years and to determine factors that are associated with poor retention among these children. So we sought out for a cross-sectional study among these children and we sorted out files from October 2015 to 2016 in the reference hospital in Yaounde. And a total of 416 children were actually analyzed, and from this sample size we got 91% of children who were still alive and on treatment 12 months after starting treatment. We identified young age less than 1 year as the main factor that was associated with poor retention, and this stipulates that there is a need for a robust prevention of mother-to-child transmission of HIV in order to effectively eliminate pediatric HIV. So what happens? Many studies have revealed that retention is being carried out, but the participants in retention studies are mostly adults, and children are most often left to the background. Children are somewhat relegated, and so the estimates for children cannot be easily calculated. Therefore, the number of children that stay in treatment after 12 months cannot be easily calculated, especially in Central and Sub-Saharan Africa where pediatric HIV still remains a significant burden. As a background, although the cascade of care and retention in adults has been well documented, data about retention in the continuum of care for children is not well known, and the main reasons for poor retention in HIV care is late identification, late start of ART, and disclosure issues, as well as stigma and financial constraints, not forgetting the poor attitude of the health staff in our setting. So children and adults and adolescents depend on adults for their care, and it equally means that the retention for children would rely on the care that the adults receive, because if children are taken care of by adults, their retention would equally be affected by adults' care and treatment. Wow. So what methodology did we use? We conducted a descriptive cross-sectional study at the Pediatric Reference Center, and the registrars of children less than 19 years living with HIV were reviewed from October 2015 to October 2016, and data that was collected in a pre-established questionnaire was entered into a PMFO version 6.3.2 for analysis and later on exported into Microsoft Excel 2010 for graphical reproduction. We use the Fisher's exact test to determine factors that were associated with retention, and the p-value of less than 0.05 was considered statistically significant. Yes.
Yeah, please do conclude your presentation. We are running out of time because of
okay, so we had, alright, so 91% were retained at 12 months as a result, and the age less than 1 year was the main risk factor that was associated with poor retention. And so we'll conclude from these findings that retention among children is less than 19 years is optimal, is near optimal, and this therefore demonstrates that there is a chance for children who are put on treatment early to have a long-term survival. But then those that are not retained are the ones that are less than 1 year, and this population would really depend on their mothers for their care, and therefore HIV needs to be eliminated in this age group. And for this disease to be eliminated in this age group, there is need for a robust prevention of mother-to-child transmission, so as to be able to enable children to be born free of HIV from HIV-infected mothers.
Yeah, Mr.
So what do we have as next steps? The next step is to strengthen prevention of mother-to-child transmission as a gold standard to eliminate pediatric HIV, and additional pediatric reference centers will need to be created to maximize the chances of prevention of mother-to-child transmission. That's what I had gathered for you this afternoon. Thank you.